So the next speaker is Paul Hodges. Paul is giving a keynote address. Paul, I've only known Paul for the last year or so. He chairs the IASP committee that's trying to better define nociplastic pain. And I've really enjoyed watching Paul try to herd cats and chair this group. The IASP processes are, let's say, imperfect. But it's really a challenge for the people that are chairing the group to sort of try to come to consensus, and Paul's really been doing a masterful job. Paul's actually trained as a physiotherapist. Much of his work throughout his career has actually been more in muscle and peripheral work and things like that, but over the last several years he's been more interested in pain mechanisms and central mechanisms. So he's going to talk a little bit about his own sort of personal journey into nociplastic pain, as well as a little bit about some of the IASP processes. Paul?
Thank you. Thanks, Dan. And I'd have to say that I completely agree with you. And if I ever fall out of, if my research funding ever falls through, I think I'm going to have to become a diplomat for the Australian government somewhere, because a lot of it is about diplomacy, of trying to understand how everybody thinks. And when Dan asked me to come to this meeting, I instantly changed plans to make it possible, because I wanted to understand a bit more about how Dan thinks and about how this group thinks, to be able to understand how we can best move forward in this idea of discriminating between these different pain mechanistic descriptors. So what Dan's asked me to talk about is defining nociplastic pain, and I will put this in a bigger context of the work that we're doing, but I'll also, one of the things I really wanted to do with this talk is to make it a discussion about some of the issues and complexities, because after all, the point of this is to understand, well, what are some of the targets for research over the next few years? And to do that, we need to uncover some of the inconsistencies or weaknesses within our thinking about these ideas like nociplastic pain. So, as Dan also mentioned, I did start my research career, or my career as a physical therapist, and that was decades ago, and I have for a lot of that time been involved in the development of interventions that target the body. So changing the way that people move, change the way that people load their body in order to manage low back pain. But of course, as has been mentioned throughout the day and everybody's understanding, is that back pain is a very complex condition. There are some people for whom changing the way they move and use their body may be relevant, and there's some people for whom that is irrelevant. And one of the motivations for me to start thinking more carefully about how do we discriminate between these pain mechanistic descriptors is to try and be able to assist clinicians to make a decision about where do you put your energy. How do you prioritise the treatment that you apply to an individual? And that then spread forth with this work trying to do a better job in clinical practice of discriminating between these pain mechanistic descriptors. So this slide, and you're not supposed to read the words, you're really just supposed to see the complexity, is some work that I did with Jacek Kolovecki, who's just down the road in East Lansing. And what we did was to ask a group of experts to tell us how they felt that back pain worked. We asked them to have these three features of pain, quality of life, and disability, and to specify all of the things that they felt contributed to that and influenced that. And what you can see is the enormous diversity of opinion, but also enormous diversity of reality of this condition of back pain. So it's clear that chronic pain, not just back pain, is multifactorial and heterogeneous. Most current treatments, no matter what pain condition we look at, have modest effects. And really, in the back pain world, there was this big move towards treat back pain as a non-specific condition, do these really simple, generic treatments, and let's hope it works. And it didn't. And it's the black box approach to non-specific low back pain isn't working at all. And we need to do better at trying to work out how can we match the right treatment with the right patient at the right time. And the foundation for this whole idea was that, well, maybe the identification of pain mechanisms is a way that we might be able to guide the matching of treatments to individuals. So I don't need to present this slide at all, but of course, nociceptive pain is pain that arises from actual or threatened damage to tissues. Neuropathic pain is caused by lesion or disease of the somatosensory nervous system, and nociplastic pain is pain that arises from altered nociception after you've excluded nociceptive and neuropathic. We'll come back and talk about that in a minute. So, nociplastic pain is clearly important, and every speaker today has already identified that there are several key reasons why we care about identifying nociplastic pain. Of course, it can help us understand why a person has a particular presentation and helps us explain to our patients why they're presenting. And it's a huge advance by understanding this idea that nociplastic pain is a condition in itself. The potential relevance for evaluation of prognosis, and of course, the potential to guide matching of the right treatment to the right patient at the right time. We do not yet have convincing evidence that matching treatments based on pain mechanism is more effective than when we apply treatment that is not matched. But I think we're a long way towards evaluating that, and some of the work that we heard this morning from Matt, those data have the opportunity to help support those decisions, that evidence, but we're not quite there yet. And I'll come back to that at the end and talk about what I think are some of the key topics that we need to resolve. So the idea, of course, is that if the pain is associated with a nociceptive mechanism, go crazy. Try and find the source of that nociception and treat it. So do whatever peripherally acting treatment you think might be relevant for the specific condition, whether it's changing the way they move, whether it's peripherally active manual therapies, medications that target the source, surgical interventions. If it's nociplastic, clearly it's about reducing the amplification, modifying the altered processing, and that might be psychoeducational interventions or medication. And in neuropathic conditions, again, it depends on the mechanism. If it's a neurocompressive disorder, then maybe changing the neurocompression. If it's a non-mechanical neuropathy, maybe it's about psychoeducational and medication interventions as well. So clearly, it makes sense. But there's a whole lot we need to get to first before we can actually address the question of, does treatment work better when we apply this approach and match treatments to mechanisms? Before I start, I'm going to say a couple of quick things that I think are really critically important that I'll keep bringing up as we go through. And the first is that we need to remember that the pain descriptors are not mechanisms. They are presumed to be associated with mechanisms, but these are very difficult to measure in humans. We can't easily directly measure nociceptor activity in humans unless we use microneurography methods. So very rarely do we actually have direct evidence that a person has ongoing nociceptive input that's driving their pain experience. In neuropathic pain, there are a host of different measures that we might be able to use to identify neuropathy or the specific nature of the neuropathy. But again, for many patients with neuropathic pain, the specific features are not identified. And in nociplastic pain, we really are at the level of presumed mechanisms, and I'll come back to talk about that a little bit more in a moment. But nociplastic pain isn't a mechanism. It's a descriptor that's associated with mechanisms. The other thing that I'll say is that it makes inherently good sense to me that many patients, if not all patients, will have some features of multiple pain mechanistic descriptors. And they may change over time. So a person may begin, of course, with a nociceptive-driven pain condition that transitions to nociplastic over time. But the current definitions and the current clinical criteria don't necessarily allow that and don't necessarily enable us to identify when that has happened. So there's some issues that I'm going to come back to. So This slide I can talk about really quickly because none of it is new or surprising to anybody. So in 2017, the term nociplastic pain was defined as the third mechanistic descriptor. It had to happen because the redefinition of neuropathic pain from one of dysfunction to injury or disease meant that there were a whole lot of people who no longer had a box to fit into. Because if there was no tissue pathology and if there was no injury or disease of the somatosensory nervous system, what did they have? A non-defined pain condition. So it was necessary to create this new descriptor. But there were lots of other examples, or lots of other terms that were provided for these people, and these have now been brought together with this term nociplastic. So it is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, in other words, not better explained by nociceptive pain, and or evidence of disease or lesion of the somatosensory nervous system causing pain, in other words, not explained by neuropathic. So it's pain that's related to altered nociception after you've excluded nociceptive and neuropathic. The purpose was to identify individuals with pain and hypersensitivity in regions where there was apparently normal tissue, or tissue level changes that were inconsistent or discordant, nice new word that I've learnt today, discordant with the features of their tissue or neuropathy. Some chronic pain is better understood as a condition on its own rather than a symptom of an underlying disease. And again, it is a mechanistic term. It ignores a person's diagnosis and explains why they have pain regardless of their diagnosis. So what I want to do for all of my talk is really then discuss this idea of some issues and controversies. Some around the terminology that's used, this term nociplastic, this idea of nociplastic pain versus chronic primary pain. I want to talk a little bit about mechanisms. I want to talk a lot about identification and discrimination, and within that I want to talk about the current clinical criteria for nociplastic pain, the idea that there should be the opportunity for coexisting pain descriptors, and then this idea of discrimination. And the clinical criteria for identifying nociplastic pain is a very different purpose than discriminating it from other pain descriptors, and I'll explain why a little later. Where are we at, and some ideas around guidance for treatment matching. And then I also want to come back to an issue related to this, the back and forth research translation between animal and human research, because the identification or this new evolving understanding of pain descriptors, these three pain descriptor groups, probably help us solve some of the problems with translation of animal research to humans. And I'll talk a little bit more about that right at the end. So the term. So we did a systematic review 10 years ago where we looked at all of the different terminologies used to classify pain with some association with mechanism. And it's a dog's breakfast. I don't know whether you have that term, but I'm sure you'll understand what it means. It's messy. And what you can see here is all of the different terminologies that have been applied to this group of people who have pain that isn't explained by neuropathy or tissue level changes. And some of them were very problematic. Some of them are challenging, as I'll talk about in a moment, in terms of this conflation of central sensitization with this idea of nociplastic pain. So lots of different terminologies are used, so the literature is extremely messy. And if you ever try to do a systematic review, understanding some of the mechanisms or treatments, it's confounded by the fact that there's lots of different terms used to describe the patients. So the term nociplastic pain is really referred to as a placeholder. It's a term that applies to this third category of mechanistic pain features, and we've got it until we can understand more about the underlying mechanism. Is it one group? Is it two groups? Is there a term that encapsulates all of those different presentations? So it's called a placeholder because we know there's something there. We just haven't yet completely resolved what it is. The term, in my eyes, is really problematic, and I think this is the thing that I hate the most about it, and about all of the idea of neuroplasticity, and that is that the term plastic is not the right word, because plastic deformation means that it is a change that cannot return. I think that's a really unhealthy message for us to be giving people who suffer from nociplastic pain. So I think nocielastic would be better, because that means that it can come in and go, and you can go out and you can come back to the same nervous system. But it tells us that it's non-recoverable, and I don't think that's the right message that we want to get. Of course, it's probably only the engineers who've got pain who realise that, but I think it is a hint of a bad message. The other one, and Dan mentioned before that some of the processes in the IASP are a bit clunky, and one of the problems is that there's a whole lot of people working on terminology at all different times, and it doesn't necessarily work when you put it all together. So nociception, but according to the IASP, is the neural process of encoding noxious stimuli. A noxious stimulus is a stimulus that is damaging or threatens damage to normal tissues. So in order to have nociception, you have to have an input related to damage or threatened damage of a tissue. And then nociplastic pain definition says that you have to have altered nociception despite not having any any actual or threatened tissue damage. So it's contradicted itself. So we need to go back now and change the definition for either nociception or noxious stimulus in order to make it consistent. Because there's clearly no neural processing of encoding something around the nociception pain experience, but it's not about the encoding of a noxious stimulus. There's something more. So the terminology task force has some work to do. The next thing to think about is this idea of chronic primary pain. So you've heard, I'm sure you all know about the idea that the ICD-11, a separate group of individuals worked on developing the criteria, this idea of the chronic primary pain, at the same time as the nociplastic definition was being created in the clinical criteria. And they're very, very similar, but they're not the same thing, and we need to understand why, because we can't mix them up. So the chronic primary pain is pain that has persisted for more than 3 months and is associated with significant emotional distress or functional disability, and the pain is not better accounted for by another condition. Sounds very similar to nociplastic pain, but it's purely a diagnostic concept. You don't have to satisfy some criteria for what nociplastic pain is founded on. So nociplastic pain is founded on a mechanism that means that there can be local sensitivity despite no injury or threatened damage to tissue, and despite no somatosensory nervous system injury or damage. So to have nociplastic pain, you have to have evidence that there is local sensitivity without those things, without evidence that's nociceptive or neuropathic. For chronic primary pain, you don't. So chronic primary pain also includes the conditions where there might be pain without local sensitivity, where it's unexplained. So although they're very similar, everyone with nociplastic pain has a chronic primary pain condition, but not everyone with a chronic primary pain condition has nociplastic pain. So they're not the same term. In terms of mechanisms, as I mentioned before, nociplastic is not a mechanism. We can't say this person has nociplastic mechanisms. They have mechanisms that might be accounting for their nociplastic presentation, but it's not in itself a mechanism. And there's many possible mechanisms, and you've heard lots of evidence today of different brain changes that are occurring in people with nociplastic and these chronic overlapping pain conditions. We did a systematic review, again, years ago, where we showed that everyone is talking about a whole host of different possible underlying nervous system modifications that might be explaining nociceptive presentation. Amplification is core to that, as Dan mentioned early on. So amplification, facilitation, hypersensitivity, increased excitability, a whole host of different mechanisms that could account for that. There are some specific mechanisms that have been described, such as loss of descending inhibition, enhanced facilitation or wind-up, ectopic discharge of neurons, A-beta fibre sprouting, a whole host of biological changes that might account for this amplification. We often describe central sensitization as being the major mechanism. Of course, one of the things that we need to remember is, just like everything else, we can't conflate the terms nociplastic pain with central sensitization. A person with acute pain can present with central sensitization. They can have sensitivity where there's expansion of the receptive field, adjacent sensitivity of other areas, but that doesn't necessarily mean that the person has nociplastic pain. So it's not synonymous. When you test a person and they have evidence of nociplastic pain, some of that could be mediated by peripheral sensitization as well. So it's not just central sensitivity. We did some experiments several years ago where we looked at people with acute low back pain episodes, and then we followed them for a year. We took lots of evaluation of sensory sensitivity. You can't be sensitive to pain. You can have an exaggerated pain response to a sensory stimulus, but you can't be sensitive to an output of your nervous system. So that slide's wrong. Times change, terminology gets refined. But we measured lots of things about sensitivity to sensory stimuli, lots of other cytokines and other things. We measured it at baseline, we measured it at the outcome, and then we identified people who had poor recovery, good recovery, or partially recovered. What I want to show is that there was a high proportion of the people in the acute back pain time period within a week of their onset of their episode who were sensitive. And my slide doesn't want to show for some reason. What you should be seeing on the right-hand side of that slide is evidence that shows that people with an acute episode of low back pain often present with sensitivity in their upper limb. So there's remote sensitivity present in these people with an acute episode of low back pain that would be consistent with this idea of central sensitization. It's the only way you can explain why their hand is sensitive. What we then did was to look at these people and track them over 6 months, and we identified the people with good and bad outcome. And what you can see in this slide is this is the sensitivity to pressure stimuli in the thumb and the back, heat stimuli, cold stimuli, and then conditioned pain modulation, and then these measures related to depression, catastrophizing, and sleep. So what you can see here is blue means a low amount of pressure, evoking a noxious response. This is the same thing here with blue is the more sensitive here. The red is more sensitive because a higher cold means more sensitive. So you can see that these people have got a bit more blue and a bit more red than these people have. And so this is sensitivity in the remote region. And what we found was that there was a group of patients who were sensitive at baseline, so this is each column is a person, each row is these measures. There's two groups who are sensitive at baseline, but only one of them had a bad outcome, and they were the people who also were depressed or had catastrophizing and and disordered sleep. So this relates to what I asked Matt about earlier, and that is that simply being sensitive at baseline, it's not telling you they're nociplastic, but it certainly is setting them up for a poor outcome. And it's only setting them up for a poor outcome if it's combined with these other comorbid features that seem to be commonly associated with some of the things that we think about in terms of nociplastic pain. So these sensitivity measures, they're telling us that there is something going on in the nervous system early, but we can't call that nociplastic pain because it doesn't have the other features yet. The next problem with central sensitivity is that we cannot measure it in humans according to the International Association for the Study of Pain. So central sensitization is increased responsiveness of nociceptive neurons in the central nervous system to their normal or subthreshold afferent input. Sensitization is increased responsiveness, blah, 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 blah. But the note is that it's a neurophysiological term that can only be used if you can measure the input and the output of the nociceptive neuron, which we can't do in humans. We can do it in a rat, but we can't do it in humans. So there is a very strong and influential group within the IASP who have argued, and there was 2 symposia at the last World Congress of Pain that argued that we should never use the term central sensitization for humans. I think that's highly problematic for 2 reasons, and that is we'll all start creating our own word to mean the same thing, and then no one will know what we're talking about anymore. The second thing is that central sensitization has already made it to the community. So I don't know who in the group is a patient and community partner of this in the group, but I'm sure that all of you have heard of this term, central sensitization. And I worry that if we now say, oh no, it's not that anymore, it's something else, that all that does is confuse the messages that we're giving around this important concept of central sensitization. So we're currently writing an opinion piece where we're getting both of the factions to present their arguments, so we can try and at least expose the pros and cons for this decision. So my preference is that we call it something like central sensitization. Maybe it's central sensitivity. Maybe that'll satisfy them, because it's not exactly the same word. Anyway. The next thing I want to talk about is identification and discrimination. So one thing, Eva Kosek, who's the lead author of the clinical criteria and the paper describing this term nociplastic, is adamant that it can't be, nociplastic can't be a diagnosis by exclusion. It can't be a catch-all after you've excluded nociceptive and neuropathic. It has to be its own clinical entity to ensure that it actually makes sense and that it's appropriately evaluated in terms of mechanism and treatment outcomes. So it's not a catch-all. It's not that if you don't have nociceptive, if you rule out nociceptive and neuropathic, then everybody else is nociplastic. That's not the case. There still needs to be this opportunity for a box who are called the undefined or unexplained pain conditions. So it must be aligned with features consistent with this idea that the foundation of nociplastic is that there's local sensitivity without a reasonable justification for that based on a nociceptive or a neuropathic mechanism. So some conditions clearly have documented changes in nervous system processing or nociceptive processing, which we've talked a lot about today. So there are some conditions that clearly there is evidence of nociceptive processing changes. We do need to decide, well, what is a sufficient amount of evidence to justify when it actually is evidence of nociceptive dysfunction or abnormal processing of nociceptive information? What's the threshold for that? But that's something that the research world needs to consider. And clearly, if we're going to match treatments to mechanisms, we need to be able to confidently identify the descriptor that is associated with a person's presentation, to be able to use that to guide treatment matching. And then, of course, we need to test the clinical validity of that. So does treatment allocation based on this identification of mechanisms actually lead to better outcomes? So there has been a lot of work put into identifying clinical criteria to identify nociplastic pain. So are they enough? So what's been generated is features that are used to be confident that a person has a presentation that would be explained by this nociplastic pain descriptor. But we need to decide, is that actually enough to then discriminate it from neuropathic and nociceptive pain? So the clinical criteria identifies features that must be present to argue that it's nociplastic. But for discrimination, we don't actually need that. What we actually need is features that are only present in nociplastic pain. So I'll explain what I mean by that by showing you what the nociplastic criteria are. So have to have pain for 3 months. If your pain's been there for 3 months, then it could be nociplastic. If not, it can't be, according to this criteria. Is it regional rather than discrete? Yes, could be nociplastic. Could nociceptive mechanisms be entirely responsible for the pain? No. Could be nociplastic. Could neuropathic mechanisms, so related to injury or damage or disease of the somatosensory nervous system, can they explain the pain entirely? Then it's not nociplastic. If no, it could be nociplastic. And then evoked sensitivity within the region of pain, and it's possibly nociplastic. And then if it's associated with these other symptoms of hypersensitivity of the sensory systems, then it's then likely to be probable nociplastic pain. So you can already see that there's some problems there in that not everyone with pain for 3 months has nociplastic pain. Not everyone who's got pain locally has nociplastic pain. So to have nociplastic pain, it has to be painful locally, but also it's likely to be painful locally if you've got neuropathic or nociceptive pain. So the things that you need to have nociplastic pain are not necessarily the ideal candidate measures to discriminate it from the other pain conditions. So one thing that has been mentioned is this idea of these non-painful sensory symptoms, and Dan mentioned many bits of evidence to argue for the importance of these non-painful features of nociplastic pain conditions, so fatigue and the multisensory sensitivity. That's not a view held by everybody, and one of the things that means that advocacy, diplomacy in the terminology task force is so important is because there are people who think that the only things that should be included in criteria are pain-related features. But clearly, there's a strong argument that these things help us understand when a person has nociplastic pain. And as I mentioned, many of these features are not useful for discrimination, but they're very useful for confirming that a person has nociplastic pain. The other thing that's a problem is that these clinical criteria may explain that if you have nociceptive pain that can explain the condition, then it can't be nociplastic. Neuropathic, then it can't be nociplastic. And that's a problem because what does entirely explained mean? And if so how much of features of nociplastic pain do you need to have to decide, well, in fact, it's a mixed pain condition and elements of both? And Eva's very adamant that you can't think of it as having a proportion of this and a proportion of that. It's either, if it's entirely explained by the other conditions, it's out. If it's not entirely explained, it's nociplastic. And there's a lot of confusion, particularly because there are no clinical criteria for nociceptive pain. In the absence of clinical criteria, how do we know when someone's got nociceptive pain? And that's a current task that the task force is about to undertake. So can these different pain mechanisms exist? Clearly, you can have two separate conditions at the same time. So you might have fibromyalgia and fall over and sprain your ankle. Clearly, two different mechanisms concurrently. Or it might be that this one condition has an evolving presentation from a nociceptive to a neuropathic nociplastic condition. And our current clinical criteria don't enable us to identify when that might have occurred, because you don't know when is it sufficiently no longer nociceptive for it to be now nociplastic. We need to work on that. There is also a group who are very strongly advocating that we need a fourth pain descriptor of mixed pain. I don't advocate for that approach because I think it's more important to understand what it's a mixture of than just to say that it's mixed. Because if it's just mixed, then we're back to the black box. We don't know what to do. But if we understand what it's a mixture of, we have targets that we can apply our treatments to and work out what might be the most important treatment at a particular time. So I don't advocate the idea that we need a fourth pain descriptor of mixed pain. If anyone in the group thinks we should, I'm very happy to chat in a non-confrontational way, because I like to hear everybody's opinion about why they think the way they do, because it helps understand how we can move the field forward. So there's challenges. There's no clinical criteria for nociceptive pain. There's no direct measurement of central sensitivity in humans. neuropathic questionnaires were developed before the redefinition of neuropathic pain. So there's a whole lot of studies out there that use Pain Detect and Neuropathic Pain Questionnaire to identify neuropathic pain patients, but it doesn't discriminate neuropathic from nociplastic because they look for the symptoms are related to dysfunction. So the neuropathic questionnaires are not enough by themselves. And the central sensitization inventory, it might be more commonly to have common to have a high score in people with nociplastic pain, but it's not linked to a specific mechanism, and it's not solely elevated within that group. So we've got some work to do, and what the Terminology Task Force is working on is a tool to discriminate between nociplastic neuropathic and nociceptive pain in a clinical environment. So the task force plus an external panel of 50 people from huge diversity of disciplines, geography and gender. The process started with systematic reviews of the whole philosophy of these mechanistic pain descriptors. We then distilled from all of those studies all of the tools that had been proposed to help discriminate, of which we found 200 different tests that need to be applied. Clearly not clinically viable to do 200 tests. Clearly we need to refine that down. So we've initially put together a expert panel to help distill down from 200 to something more manageable of the measures that were most likely to be useful, and that is measures that are unique to one or at least only present in two of the pain descriptors. And then the next phase is to then distill that even further down to a clinically viable set of tests. So this is a really blunt overview of some of the things that are most important. Clearly, there are going to be features of pain that relate to these pain types. So nociceptive pain should be localized or discrete. It should respond in a predictable way from a musculoskeletal perspective, turning on and off with specific movements and postures in a predictable manner. With quantitative sensory testing, there should be normal sensitivity remotely. Questionnaires are often normal, but not necessarily. They may be depressed or catastrophizing. They may have other features, but it's not as common in the other groups. And there has to be a history of a relevant injury or tissue impact. Nociplastic pain clearly is going to be around features like an unpredictable or disproportionate response to stimuli in a multi-site, broad, widespread regional distribution. Hyperalgesia or hypersensitivity in remote areas as well as locally. The central sensitization inventory might be increased, but not necessarily, and a mismatch between the history and the presentation. And then neuropathic is clearly going to involve the clinical features associated with neuropathy of features like the electric pain, the neuroanatomically plausible distribution, positive and negative signs that indicate a neuropathy, such as numbness and pins and needles. There might be sensitivity remotely, but maybe that's indicating a transition to a more nociplastic presentation. The questionnaires should be elevated, but that doesn't discriminate them from nociplastic, and there's got to be evidence of a history or actual clinical evidence of nerve damage or dysfunction. So they're the kinds of features that we're using to create this tool to help discriminate between the pain types. What we're doing is developing a tool that has three versions: a self-report tool, a simple clinical tool, and an advanced clinical laboratory version. Clearly, decreasing feasibility, probably increasing accuracy, but we want to do all three because maybe the questionnaire is enough to at least give us an initial screening. So we're developing three versions that we can evaluate at each step of the process. By applying the test, we'll then there's an algorithm that will be applied to evaluate the likely probability of each different pain mechanistic type, and then they'll end up with a score something like this. So this is one patient where they may have a 97% chance that their pain is nociplastic. They may have a 70% probability that it's neuropathic, so it has some features of neuropathic, but more features of nociplastic. And then you would decide it's predominantly nociplastic, and then you would apply an intervention that is targeting the nociplastic features. So that's the model that we're developing, and then we'll evaluate. So for each patient, they'll have some idea about, well, what's the relative distribution of the different mechanisms. So not assuming that one has to stop before the other starts, and they can actually be coexisting, and understanding where does that change. So we've finished the ranking and prioritisation of the candidate measures. We're currently operationalising that, so turning it from an idea into an actual test that we can apply in the clinic. I'll just give you a quick idea of what it looks like currently for nociplastic pain. So there's an item related to the widespread regional nature of the pain, and that's being evaluated with an electronic body chart. So drawing on all of the work that's been done with the Michigan body chart work and many other groups, using AI to analyse the distribution of pain, and that the same AI is used for each of the different pain types. It's enhanced by clinical examination for the simple clinical and the advanced clinical version. We evaluate generalised hypersensitivity and evoked hypersensitivity in remote regions using simplified versions of QST for the simple clinical version, asking questions in the self-report version, and then more advanced clinical testing. Questionnaires to evaluate for the presence of symptoms of fatigue, sleep disturbance, cognitive problems. Clinical examination related to pain being not provoked in a clear and consistent manner by provocative stimuli, and that's something that is done with questionnaires and with physical examination. The central sensitisation inventory, it may or may not help, but we're including it at least initially. Evoked hypersensitivity to stimuli that can be elicited clinically in the area of pain. That won't help us to discriminate, but it has to be present. Hypersensitivity of special senses through questionnaires. Diagnosis of fibromyalgia as one of the criteria. Not one of these criteria is sufficient to have nociplastic pain, but together they may increase our confidence. No history of injury or condition affecting the neural or non-neural tissues that could explain their pain presentation, and a diagnostic test failing to confirm the presence of a condition. So those last two are going to be highly problematic to provide the clinical guidance and criteria for, because what's sufficient evidence of a diagnosis of tissue injury? Clearly we see X-ray changes in people who have no pain. So those last two may actually fall out in the end because they're not precise enough. So what we've done is to develop tools for each of the different test items, and then what we'll do is through a large cohort study and clinical trial, we'll then refine that down to the tools that actually make a difference, actually contribute to the classification. So we've done some preliminary validation on a group of 350 people with chronic musculoskeletal pain with a preliminary version of the test items. We took this group of 350 people, all of the test outcomes, and we didn't tell the clustering how many groups there should be or what features should map together. We just asked the clustering to identify the most likely clusters within that group. And it turns out that there were 3 clusters in the group. And then what you can see on here is each colour is a different cluster, and the dot on the end of each of these lines is what a clinician had decided the person's predominant pain mechanistic descriptor was. And you can see there's one cluster that seems to map onto nociplastic pain, one to mostly neuropathic pain, and one mostly to nociceptive pain. Now, this is a group of patients attending a chronic pain management clinic, which is why nociplastic is so dominant. So we then looked at the features, and what you can see is that this cluster of nociplastic people are identified. So each column is a person, each row is a feature. The blue means it's present, white means it's not. And you can certainly see that there's a cluster of features that seem to characterise the people with nociplastic pain. There's some of these features that are not useful at all. So already we can start to decide that some of the features are not going to be helpful for the discrimination. We also found clusters for neuropathic and nociceptive. So it seems that these features do cluster to different subgroups within the chronic pain population. So the next steps are to define the preliminary algorithm, so the weighting and the calculation to identify the pain types, to refine that with some patient vignettes, to validate it in a cohort study, to evaluate the psychometric properties, and then to do the ultimate, the clinical validation study. So very quickly, just in terms of guiding treatment matching, So a really critical thing that we need to remember is that the pain descriptors don't tell us what treatment to apply, but they tell us which toolbox to select the treatment from. For example, if someone with presents and they have nociplastic pain, it doesn't tell us which particular medication, which particular psychoeducational intervention. We heard this morning about all these different versions of cognitive behavioural therapy. So it tells us that if you've got nociplastic pain, don't deal with the tissue. Choose a treatment that changes the amplification, but it might be there is a selection of treatments from which to choose for that. If someone has nociceptive back pain, it doesn't tell you exactly what surgical intervention or physical intervention to apply, but it tells us that it's reasonable to search from amongst that toolbox what tool might be appropriate. So we can't think that these pain mechanistic descriptors are going to tell us which treatment, but it certainly is supposed to tell us which toolbox the treatment should come from. So that's a bit of a challenge for the clinical trial piece. Clearly we need to do a clinical trial to test the clinical validity of the approach. So does a person have a better outcome when you apply the intervention to the right person? There is no good evidence yet because we don't really yet have any good clinical trials that have discriminated between the pain mechanistic descriptors very well. So, for example, in knee osteoarthritis, there's evidence to show that people with knee osteoarthritis, many of them have nociplastic type features, but it was called neuropathic-like because they used neuropathic questionnaires, which tell you that there's sensitivity, but don't necessarily tell you that it's neuropathic or nociplastic. So there is evidence to show that 40% of people with osteoarthritis have evidence of this neuropathic type feature. High scores on these tests, probably sensitivity, probably nociplastic pain. QST, many people with knee osteoarthritis have increased sensitivity in regions adjacent to their osteoarthritic knee or in remote sites. So there's evidence that many people with osteoarthritis have a nociplastic type presentation. So the assumption would be that if you do a knee joint replacement on someone who's got a nociplastic presentation, it shouldn't work as well, and Dan's already mentioned some of the data for that. There's a systematic review that shows exactly that the people who are most likely to not respond to knee joint replacement to reduce their pain are those who have the remote sensitivity. So there is evidence to suggest that treatments don't work if you apply them to the wrong group. What we don't yet have is the evidence to show that they do work better when you apply them to the right group. So there's some nuance in that. So there's clearly work to be done. So we need to identify the pain descriptors better, and that's what we're currently making progress towards. We then need to do the definitive trial that evaluates toolboxes applied to different pain mechanistic clusters, and then to show that the treatments are better than when it's unmatched. And of course, we need to understand what's in that toolbox, and that's something that clearly needs to be worked on. If we're really trying to manage people's pain, of course, it has to be multifactorial, and all of those other things that we talked about that you've heard about today, and I'm sure you think about all the time, things like sleep and other environmental factors. Proper management of people with chronic pain does need it to be multifaceted. It's not just one treatment to target one mechanism. So there are some complexities in unpacking this. I have run out of time to talk about the animal to human back and forth translation piece. What I want to say, with a picture of a very cute mouse, is that we have a fundamental problem in that in animal research we know what we've done, so we know what the pain mechanistic descriptor is that applies, at least initially. We try a drug, or we develop a drug that targets that disorder, that particular pain mechanism. Then we apply the drug to humans where humans are messy. So we might develop a drug for a neuropathy. We test it for people who've got peripheral neuropathic disease, associated with diabetes. We don't exclude the ones who've got nociplastic pain, and we've got this mix of really complicated presentations. The drug doesn't work, and we've wasted $20 million of development in getting that drug to market. So we need to do better at being able to characterise humans so that the right interventions are tested on the right people. But we also need to understand in animals there is increasing evidence to suggest that even the pure models that we apply in animals are not clean. So an animal you may give an injury, they develop a condition, but it actually may transition to a nociplastic pain condition over time. And that's being ignored at the moment because no one, or very few people in the animal world, even think about nociplastic pain. There's a lot of confusion about what the term means. So we need to understand that. And one of the problems is that in animal research, if a couple of animals do something different, you throw them out. And they're probably the ones who are developing the human interesting heterogeneity of response that we need to understand. So what we're doing now is going back to some data from a whole host of animal projects to understand, are those outliers actually telling us something really interesting? And we're mapping our clinical criteria that we've developed for humans in terms of discrimination to animal testing to be able to understand whether we can better characterise the pain presentations within animal models. When is it transitioning to nociplastic? How can we use that to better guide the development of interventions? So my final slide is really to say three things, and that is there's a whole lot of interesting ideas around nociplastic pain, but there's clearly things that need to be done. We need to change it from a placeholder to a clear understanding of the mechanisms that underlie it so that we can be even more precise in measuring it and identifying it. We need to do better in discriminating in clinical practice, and that's the point of the work that the task force is doing. But ultimately, we need this next step, and that is the clinical validation. Are treatments that are matched to pain mechanisms more effective than when they're not? So I'll finish there by acknowledging the wonderful people I work with on the terminology task force, and again, say thank you to Dan for the invitation to be here. Thank you.
We have time for a couple questions for Paul. Yeah, I forgot. So a reminder, go into slido.com, NOC25, and just start putting in questions you either have for Paul, questions for the panel this afternoon. We need input from the audience. So go to Slido, please. Now, questions for Paul.
And I do have a question for Paul.
Okay, go.
So Paul, in the era of precision health, this gets to your final point, what is the clinical or practical value of categorizing pain conditions into nociceptive neuropathic and nociceptive? Well, it's like a real world
yeah. I have enormous optimism for what we will be able to use it for. As I said, one of the problems is it won't tell us exactly what treatment to use. I wonder whether the most valuable thing is to tell us what not to use. It'll clearly tell us when not to go to a surgeon, because that's not, and I work with a lot of surgeons, spine surgeons in particular, and they're desperate to understand who are the people who are not going to respond because it's their biggest problem. I think it'll also help us do better in the physio world, the physical therapy world. We've got this pendulum that swings in our profession of body, mind. And for 10 years, it was all about the body, do lots of manual therapy and exercise. Then it swung to do psychoeducational interventions. And clearly, it's not either or. We need to be somewhere in the middle. And I think for the physiotherapy profession, it'll be really valuable to help give justification for why you would choose one or the other. So I do think there's some really great clinical utility, but maybe its most potent thing is about telling us what not to do. Yeah.
Andrew?
Thanks so much. That was a fascinating talk, and thanks for helping us clarify our language, because that usually helps us clarify our thinking, and I think we really need to do that. There's a lot of terms that have been around here. When I was a graduate student, that was an incredibly hard thing to figure out, was what people were calling pain all the time. I have a question that relates to treatment responses. Do you think there's a role for that in defining pain mechanisms?
Yes.
And specifically where you see somebody fail a peripheral treatment when they did show signs of tissue damage and inflammation, how should we think about them? Because it looks like right now there is some provision that if you have something that can explain the pain, then we're putting them out of that nociplastic category, but we know a lot of the people that even when that pain is treated appropriately and the inflammation is gone, they're still going to have the symptoms.
Yep. And so treatment response is clearly one of the ways to clarify a mechanism, potentially. There's some huge problems. So in our clinic, when we developed the discrimination tool, we actually took most of them out, but it's purely because many of the treatments that are proposed you couldn't use as a test in a clinic, in a tool. Like one of the suggested criteria was positive response to surgery. You clearly not going to do. The other challenge, though, is the placebo response, of course, in that there will be a proportion of people for whom you generate a true neurophysiological response to the act of taking a drug that changes their pain because it's changing central processing and not because of what it's doing to the tissue. So there is murkiness even in that. In the animal literature, we actually set out, Marie Smith, who's a superstar of the drug discovery world, we included her in a panel to help us understand, well, what are the drugs that we would use in the critters to be able to just identify which of the mechanisms it is. No one could agree. Opiates shouldn't help for nociplastic pain, great, but no one could agree on what they could help for. And so there's a lot of controversy, even in the really refined animal world, of what should impact what. Duloxetine's a wonderful example because it should reduce sensitivity of neurons, so it should be helpful for nociplastic pain. There is a trial in sciatica that shows that it was more effective for the people with confirmed neuropathic pain than those who had the probable or possible neuropathic pain and probably nociplastic. So there's some nuance in these drug effects that we need to understand more before we can actually use them as a tool to clarify you've got pain A, B or C. Yeah, but it makes a whole lot of sense. Yeah.
Great, thanks so much, Paul.